So treatments, here's what we've been trying to get to. We've been trying to get to treatments for a while, but we've got to reduce the preload. We got to reduce the amount of pulmonary venous return. We've got to reduce the systemic vascular resistance or the afterload, and we've got to use some sort of inotropic or contractility support. So we've got to use something to help that heart contract. Those are the things that we're trying to do when it comes to some of the treatments. When it comes to the preload, what we're trying to do is use nitroglycerin, which is a rapid-acting vasodilator. If I vasodilate, I open up and I have more opportunity for the ventricle to fill. I want to use some loop diuretics. This decreases the amount of preload through excreting extra fluid. And then I can use morphine sulfate as a vasodilator, and I want to be careful of the downsides. It can lead to nausea, vomiting, and respiratory depression. So morphine is not a common use for pulmonary edema, but it can be used as a vasodilator in a pinch. So other ways that we can reduce the afterload is we can use what's called ACE inhibitors, or anything that has a pril at the end of it. P-R-I-L. These are ACE inhibitors. Nitroprusside. This is a smooth muscle relaxant, and it reduces the afterload and mildly reduces the preload. So if we can get vasodilator effects after the ventricle, then this causes vasodilation and will reduce the afterload. Other treatments we're going to look at are the inotropes. These help with contraction. These help with the contractility of the heart. We've got dobutamine, dopamine, norepinephrine, and milrinone. These are all different types of inotropes. When we look at antidysrhythmic agents, if we have a heart that's not beating in sync with itself, then it will not move fluid very well. It will not move the blood flow around the body very well. So if we have bradycardia, we have severe bradycardia, we can use atropine to increase the heart rate. If it is a tachycardia, we can use digalis or procainamide, metoprolol. These are all different classifications of medications that will help reduce the antiarrhythmics that are happening. The last one is we can actually increase the oncotic pressure by giving albumin. So if I can increase my oncotic pressure, then I can increase the amount of fluid that stays in the vessel and does not escape out of the pulmonary capillaries into the alveoli. Other strategies, if they have a history of smoking, sometimes this is what we need. If we can utilize some smoking cessation strategies, a weight loss program, or other ways that we can control cardiac arrhythmias, and other ways that we can control the systolic hypertension. Typically, these are medication induced, but we don't have to use those if we can get them off of the cigarettes, if that's what they're doing, and we can get them to lose some weight. The last thing is we're going to get these patients on some positive pressure ventilation. The latest practice is to have a CPAP 10 to 12, greater than 50%, whether that's on a mask, whether that is mechanical ventilation, whatever that is, you want to use higher PEEP levels with these patients. It does not push the fluid out of the alveoli. It increases the surface area of the alveoli, so we have more surface area to utilize in diffusion of oxygen into the bloodstream and removal of carbon dioxide. So CPAP 10 to 12, loop diuretics, and nitroglycerin are all three part of the treatment plan when it comes to pulmonary edema. If we need to use some ACE inhibitors, to create some vasodilation, to improve the preload and reduce the afterload, those are viable options as well. So lots of information here when it comes to pulmonary edema. We hit both cardiogenic, non-cardiogenic. We looked at the etiology, the pathophysiology, clinical manifestations, diagnostics. Remember those lab values. Remember those lab values, especially with the BNP, brain nucleic peptide. Your chest x-ray, you're going to see fluid in the bases, or you could have fluffy infiltrates centrally located, like a bat wing or a butterfly wing. So the curly A, B, and C lines. These are, and then your treatment with CPAP 10 to 12, loop diuretics, and nitrates, if the blood pressure can handle it. If your MAP is less than 60, then we're not doing it. We're not giving a vasodilator for that blood pressure to tank. So CPAP 10 to 12, loop diuretics, and nitrates if the blood pressure can handle it.